Good afternoon. I'm Julia Platts. I'm a consultant in diabetes in Cardiff and Vale Health Board, and I'm also the National Clinical Lead for diabetes in Wales. And I'm here today with...
Good afternoon, everyone. My name is Claire Green. I am an Assistant Director in the Finance Delivery Unit, and as part of my role, I support local and the National Clinical Programme for Value-Based Healthcare.
And today we're talking about our project on optimising outcomes in diabetes. And I'm going to start a little bit by just telling you the scale of the problem in diabetes. We've got almost 200,000 people in Wales living with diabetes, and that's actually 7.6% of the population over 17 years. Most of this, 90%, is type 2 diabetes. And we also think we've got around 65,500 people who've got diabetes who don't know it, and over 500,000 people who are at high risk of diabetes. So you can see that we've got a bit of a tidal wave of diabetes in Wales, and if we don't do much about that, by 2030 we're going to have over 300,000 people with diabetes. The cost of the problem is another very large issue. Diabetes costs about 10% of the health budget, over 500 million per annum in Wales. But the thing about this is that the vast majority, it's estimated over 80%, is actually spent on treating the complications of diabetes rather than treating diabetes itself. And the other thing to note is most of these complications are preventable. So these are just a few headlines of some of the things that can happen as a result of diabetes. We know if people have got diabetes, you're 2.5 times more likely to have a heart attack, you're twice as likely to have a stroke, you're 2.5 times more likely to have heart failure. And if you look at the people in hospital with these three conditions, about a quarter of them will have diabetes. Blindness is another complication of diabetes, and until recently, diabetic retinopathy was the chief cause of blindness in working age people. End-stage renal disease and people going on to dialysis and needing a renal transplant is another common consequence of diabetes, as is limb amputation, chronic ulceration, and disability as a result of these. For the pregnant woman, there is increased obstetric problems, morbidity, stillbirths, perinatal mortalities, and then we have a lot of acute complications of diabetes, such as diabetic ketoacidosis and hypoglycemia. So you can see that diabetes is a big burden for the person with diabetes and for the healthcare system. So I'm going to start with pregnancy first of all, because this is one of the three areas that Claire and I are looking at to see what we can do to improve outcomes. We know that diabetes is harmful in pregnancy, and if you went back around 60 years, about 2% of women would actually die during a pregnancy if they had diabetes. 10% of the babies would be stillborn, 10% would die in the first month of life. Now, we have come a long way since then, but if you look at the statistics, still 1 in 2 pregnancies where the mum has diabetes has an adverse outcome. And this slide just shows some of the top line things that can go wrong in a pregnancy with diabetes. We've talked about stillbirth, neonatal death, major congenital abnormalities, macrosomia, big babies, which causes early delivery, and then that causes all the problems with babies needing to go to special care baby unit and having immature lungs. Babies can also be small, having uterine growth restriction. There are more miscarriages, there are more caesarean sections and complications of this. For the mum can get very bad hypos and get more hospitalisation through diabetic ketoacidosis. The mum's eyes can deteriorate even to blindness in pregnancy, and the kidneys can deteriorate to the point of needing dialysis in pregnancy. And then the baby after birth can have an awful lot of complications. So these are just some of the top line things that can go wrong in a pregnancy complicated by diabetes. And I'm going back a few years to the confidential inquiry into maternal and child health, which gathered data between 2002 and 2003. And on this slide, the people in blue have diabetes, the people in green have no diabetes. And what you can see is that stillbirth is 5 times as common, a major congenital abnormality is twice as common, and neonatal death is 2.5 times as common. Next slide, please, thanks. We now do a national diabetes pregnancy audit since 2014. And this audit is aimed at looking at various areas. It asks the questions, are women with diabetes prepared properly for a pregnancy? Do we do the right things in pregnancy to minimise the harm to the mother? And do we do the right things in pregnancy to minimise the harms to the baby? What we have seen is that the stillbirth rates are unchanged over the 5 years of audit, and we're not making any progress on this. If you look at this slide, you can see about 10 per 1,000 pregnancies in type 1 and type 2 diabetes ends in a stillbirth, compared to 4.2 per 1,000 in the general population. And it's this kind of statistics why we want to look at the data differently, to try and unearth what the real problems are and what we can do to make a difference. If we look at neonatal death rate, the same applies for both type 1 and type 2 diabetes. There is an elevated rate of neonatal death compared to the rest of the population, where it's 2.8 per 1,000. If you look at diabetes, it varies between 5 and 10 per 1,000, and it's not improving. This slide shows the characteristics of women with diabetes compared to ethnicity and compared to deprivation. And what we can see is the blue bars are type 1 diabetes, the grey bars are type 2 diabetes, and we can see that type 1 diabetes is highest in the white population, but once we're looking at type 2 diabetes, this becomes far more prevalent in the Asian and Black ethnic population. If we look again at type 1 and type 2 diabetes against deprivation, we can see as people become more deprived, the incidence of type 2 diabetes is markedly increased, particularly in the most deprived population. What we know we can do is reduce harm if we get the pre-pregnancy care right, but we found that this is a really difficult nut to crack. We know that if we get the HbA1c down to less than 7%, we really reduce the risk of congenital malformation, and as the HbA1c rises, so does the risk. So, for example, if you have an HbA1c of 10%, your risks of a major congenital malformation are around 10%. So we know that we have to get the HbA1c down prior to conception to reduce this risk. We also know that women with diabetes should take 5 milligrams of folic acid to reduce their risk of neural tube defects, which are increased. And we also know these women are on a lot of teratogenic medication, which needs to be stopped. But what we have seen is that we're not making any progress in this area. The numbers of people with diabetes who are well prepared for pregnancy are low and not improving. So again, on this slide, the blue bars are type 1 diabetes, the grey bars are type 2 diabetes, and we can see that the percentage of women who've got HbA1cs in the right range for conception vary between about 15 and 18% for type 1 diabetes and around 38% for type 2 diabetes, so most don't achieve it. Similarly, with folic acid, we see a different pattern. We see around 45% of women with type 1 diabetes get the right dose of folic acid, whereas just over 20% of women with type 2 diabetes get the right dose of folic acid. And this probably represents women who are under hospital care with type 1 diabetes and not under hospital care with type 2 diabetes. but you can see that there's a great deal of improvement to be done, and you can also see that we're not making much headway with this. Some of the factors that are associated with lower preconception target attainments for type 1 diabetes are younger people, people with a greater deprivation, and people with greater body mass indexes. And for women with type 2 diabetes, the chances of not getting to target are associated with having a Black or Asian ethnicity, a longer duration of diabetes, a greater deprivation score, and also a greater body mass index. And overall, we see the data only 1 in 8 women are well prepared for pregnancy, which is pretty shameful, really. So we haven't seen any improvement. Down the bottom of this slide is 2014 through to 2018, and you can really see that we're not making any headway. There's no improvement across the years in women being well prepared for pregnancy. We can look at how long it takes for a woman to be in contact with a specialist team, and this slide says how many women were in contact with a specialist team before 10 weeks of pregnancy, because we want people to come in straight away, because all the organ development happens in the first trimester, the first 12 weeks. And what we can see is that women with type 1 diabetes in blue, a slightly higher proportion get in than women with type 2 diabetes, but again, you can see that we're making no progress with this, and we don't know why it is. I've just put this slide up to show that improvement is possible. This looks, each of the lines represents a different centre in the diabetes audit for type 1 and type 2 diabetes. And what you can see is some centres get 100% of their women into season before 10 weeks, whereas other places get down to 30–40%. So what that says to us is improvement is possible, because there's a lot of variation we see across the services. We've also seen no improvement over the years in the 3rd trimester HbA1c, despite the fact that we know even late improvements in diabetes control in that 3rd trimester can have a big impact, particularly on what happens to the baby after delivery. Again, blue type 1 diabetes, grey type 2 diabetes, we're not making any inroads. I'm going to leave pregnancy in diabetes there and move on to another area that we're looking at, and that's eye disease in diabetes. So eye disease, retinal disease, is a microvascular complication of diabetes. We know that it's very much related to duration of diabetes, and it's very much related to the degree to which people have good control of blood sugars. And it goes in a progressive type of way. It starts with background retinopathy, and then it progresses to something called pre-proliferative retinopathy, proliferative retinopathy, something called maculopathy, which affects the sight areas of the eye, and then ultimately it ends up in what we call advanced eye disease, where there's often bleeds into the vitreous. There might be a retinal detachment, and patients at this point can just present with sudden blindness. So what we see is that eye disease is often asymptomatic until advanced eye disease. So we've got to do something to detect it. And we have retinal screening services that can look for changes early on and intervene to prevent them. What we know is in Wales around 20% of people don't attend retinal screening. And these are people who often come to harm. We haven't been able to make much impact in that, and what we really want to know is why people don't come to retinal screening, because there's a lot we can do to try and prevent retinopathy, and then once retinopathy is present, there are things we can do to prevent it from deteriorating, and then when it gets to a certain stage, it will require hospitalised services by the time it needs things like laser therapy or vitrectomy. So this is another area that we're looking at. We've had successes and we've had failures in eye care, in diabetic eye care in Wales. One of the leading successes was that for years, at least 5 decades, we knew that blindness, the leading cause of blindness in working age population was diabetes. And that changed around 2009, 2010, when a paper has shown that it's no longer the leading cause of blindness in the working age population. And that's thought to be due to the success of retinal screening in Wales. However, we know that we've still got lots and lots of problems. And in the same year as that paper, the RNIB published a report, Real Patients Coming to Real Harm, that concluded 4 patients a month in Wales lose their sight. These aren't necessarily all people with diabetes, but 4 patients a month lose their sight in Wales due to delayed and cancelled appointments. And last year, the Public Accounts Committee published the management of follow-up outpatients across Wales and commented that the situation was likely to have deteriorated rather than improved. So we have a degree of work to do on ensuring that everybody gets screened and looking at why some people don't get screened, and secondly, what's happening in hospitalised services that people are coming to harm on these waiting lists. And then I'm just going to move on to foot disease, because this is another area that we're looking at. Foot disease is enormously costly, diabetic foot disease. Diabetic foot disease is estimated to cost more than treating prostate cancer, breast cancer and lung cancer in Wales. It's hugely expensive. Around 64,000 people in England and Wales probably have foot ulcers at any given time. And some of these people will have amputations. There are about 7,000 amputations, that's in England rather than Wales, per annum in people with diabetes. And if you also look at people who develop a diabetic foot ulcer, this is a debilitating condition. Only 3 in 5 people will survive 5 years with a foot ulcer. And if you have a major amputation, it's only half that number. What are the causes? Well, there are multiple causes of foot ulceration. Again, there's microvascular disease to the nerves, and that causes a sensory neuropathy, where people can't feel anything, and quite often they get trauma to their foot, rubs, step on nails, etc., which starts off a process. There's also a motor neuropathy that leads to weak muscles, so you get clawed toes and abnormal pressure points. And it's these abnormal pressure points that often lead to the formation of ulcers. There's an autonomic neuropathy, so the skin is dry and cracked and allows infection in. There's often large vessel disease, macrovascular disease, which leads to poor blood supply and ischemia. People with diabetes often have high blood sugars that predispose them to infection. And you can see there's almost a perfect storm to have a problem with the feet. We've got a national diabetes foot audit, and last year what it showed is that people with foot ulcers, less than half of them are healed at 12 weeks, and only a third of severe ulcers are healed by 12 weeks. Severe ulcers are 4 times as likely to lead to a major amputation, and 90,000 inpatient bed days were taken up in the national diabetes foot audit in England and Wales with ulcers. Now, why that is incredible is only a tiny proportion of people with foot problems actually end up in the National Diabetes Foot Audit. So there is an enormous number of inpatient bed days spent looking after foot ulceration. So it's a big problem. What we know from the audit is that time to expert team matters. So the faster the person can get, once they've got an ulcer, to the team, the more likely it is to heal. So the people who can self-refer get the best rate of healing. Those that have delayed referral are the ones that heal least. What we can see is there's variation in who does get to be seen promptly. These bars are of different areas across the country, and you can see Wales isn't too bad. It's fourth from top on this. So I'm going to stop there. What I wanted to have demonstrated is that we have a lot of problems in diabetes that we're not winning with, and we need a new way to address them. So I'm going to hand over to Claire now to talk further about this.
Thank you, Julia. And as Julia's kind of tried to summarise there and has described to you the population impact of people living with diabetes in Wales, and the multiple complications of diabetes, and the fact that although there are many complications in this particular project, we are focusing on 3 sub-pathways. We're going to hopefully share with you in the next few slides a little insight into the approach we are taking and how we might try and tackle and improve the situation, and that is to try and identify what is driving these adverse outcomes and what steps we may take to positively change the system. Not all of you listening in today may be familiar with Wales and its healthcare structure. To set the scene a little, we have in Wales a population of around 3.2 million people. The NHS and all of its services are provided and supported by 14 individual organisations, and 7 of these are local health boards. The local health boards in Wales are responsible for the planning and delivery of healthcare services within geographical areas, and these support populations that can range anywhere between 140,000 to in excess of 700,000, I'm sorry. And they cover a full range of services from primary and community care, secondary care, mental health services and tertiary services. Within the health board structure and the system, there are 64 GP clusters across Wales, and these serve populations between 30 and 50,000 patients. And these clusters work and are combined from GP practices, other healthcare providers and local services. And the reason for outlining that overall position and focusing on the almost 200,000 population we have of people with diabetes in Wales is to demonstrate that we are uniquely placed and have the opportunity in Wales to fully join up the end-to-end pathway for patients and consider how we utilise resources across the system. If you were able to attend the opening session of Value in Health Week, you may have heard Professor Alan Brace describe a clear shift in Wales to a focus on how we use our resources with a clear understanding of outcomes and effectiveness. We have a new funding formula in Wales which supports a review of all levels of the system, down to the GP clusters I described, and we have reported clinical outcomes and are developing an expanding programme of patient-reported outcome measure collection. What we need to understand now, and in line with what Julia's described about the sense of expenditure and resources that we use to support the diabetic population, is how we really do use these resources and what outcomes they are driving, and ultimately achieve a connective cycle that optimises allocation, utilisation and outcomes. And this is very much the approach we are applying to this project. You may have also heard on Monday and through various sessions in the week the need for a coordinated and a collaborative approach to value-based healthcare, and that is exactly what we're trying to achieve in this project, engaging with clinicians, service managers, finance and analytics. We are working together with the aim of improving patient outcomes. So the right place to start is the pathway, and as Julia has described, we know that adverse clinical outcomes are occurring, and we have 3 clear pathways where we hope to achieve improvements. And part of what Julia was describing in her slide deck as well is that the timing and the types of interventions are key to a patient's progression towards an adverse outcome. So looking at the pathway on the slide, certainly from the patient's point of view at the point of diagnosis, it looks like a relatively simple pathway and is not intended to be representative of an experience, because the key in this diagram is actually the individual at the effective end of the pathway, at the point of the adverse outcome, and that is our starting point within this project. we are aiming to combine, or we are combining, cost, activity and outcome data at each stage of each of the sub-pathways to gain an insight into the current impact of resource utilisation and to identify areas for consideration and potential improvements that could be achieved for the patient population. The ultimate aim is to identify where and how we may need to shift resources upstream in the patient pathway to prevent some of these adverse outcomes. It's hoped really, and our intention on the backdrop of what Julia's described, is that this will lead to a review of current service provisions, needs of patients, avoidance of disutility of care, and a true understanding of the value of the current treatments and interventions we have in place, and equally an understanding of whether access is equitable across all patients within the system. Helen Thomas, who is our director at NRIS, our National Informatics Service, described earlier in the week that data is at the heart of value-based healthcare. Dr. Sally Lewis, you will have heard describe that we need good data to support good decision making. And if you've managed to attend any of the data sessions this week, you will have seen demonstrations of what great data can tell us, sometimes most surprisingly without digging in too far. So the approach we're taking within this project is to utilise all of the data available to the system with the aim of understanding the patient pathway, the reality of the patient pathway, and the key drivers of the outcomes being experienced. Where we can, we are correlating and connecting data. However, this is not always required to gain insights. We have a vast amount of data within NHS Wales, and by reviewing the data and extracting the messages available to us, it is possible to identify areas for clinical consideration. So on the slides currently, there are names of some of the data sources we are using, and they beautifully fit into a number of boxes, and this is not an exhausted list. I suppose the thing I would highlight for yourselves is in that slide we can see information on population health, there's prevalence data, admitted patient care activity, patient level costing data. Each of these data sources are vast and contain extensive information about the experiences of our patients across the system. And what we're doing in this approach is bringing all of that data together to see what the information tells us about experiences of our patients currently. And our analytical lead for this project has loaded all of this data into a Power BI dashboard and created for us a diabetes dashboard that allows us to undertake detailed analysis of all of this data at an all Wales position and also all the way down to a GP cluster level. To give you and provide you with an example of what I'm referring to, and unfortunately this is an anonymised slide because hopefully, as we've described, this is a project that is currently underway and we are progressing through sharing and presenting some of this data. However, this shows you a data slide within the dashboard. You will see at the top of the dashboard there are a number of headings with data areas for review. Some of them will all feed back to some of the kind of clinical terms you heard from Julia: amputations, diabetic retinopathy, and there are actually many more data entries which allow us to see what data we've got across the system and, as I say, identify what is actually happening. And although this is still a slide shot of the dashboard, this is actually a fully integrated dashboard that we can use and share, ask questions of the data in a very speedy, actually, and an efficient manner, so that we can identify what information is available within the system. So just a bit of an example of what this slide is really telling us. The data reflects one financial year, and it details an all Wales position. So the statistics across the top are describing to us that in 1 year we had 556 spells across our health board in Wales. This was driven by 476 individual patients. We have an average cost per spell at the moment across Wales of £12,864. It describes the admitted stays per spell, mortality during and after discharge. There's a lot of information. And the two charts on the left-hand side of the page, the top and the bottom, are describing how that activity falls across different health boards. And particularly we can see that Health Board 7 is reporting the largest level of activity in this area. If we look at the centre of the chart, we look at the admitted days per spell, and one Health Board 4 in this example, has the longest length of stay, equally the highest cost per patient stay, which will be largely related, but it doesn't fully correlate between cost and length of stay, so that's another area of variation for us to look at. And equally we have information on mortality, as I say, during and after spell. And beneath this, we are able to view the statistics by individual Health Board area. And in this scenario, as I described, Health Board 7 stands out as a Health Board that accounts for almost just short of 40% of all of the amputation activity across Wales. The next slide then actually drills into the case mix, the actual case mix of the patients who have had amputations. And if we explore Health Board 7 a little further, which is the Health Board we identified with the largest and greatest reported activity, we can compare via the top row of this chart the patient case mix and see that Health Board 7 has the second lowest average age for a patient having an amputation across Wales. And actually almost 40% of the patients moving along into the age bands are actually below the age of 60. And further along to that, we can then have a look that this patient mix is dominated across Wales actually by the male population. And particularly again in Health Board 7, there's a particular theme and a message here already that the patients are below the age of 60, and actually many of them are men in this area. The charts directly below on the bottom row of the sheet then actually drilling, as I described, to a GP cluster area within this Health Board. So we can look by clusters, what is the average age of patients who are unfortunately having an amputation in this area, and then what is the age band split, and equally what is the male and female split. And what we've taken from this data is, you can hopefully see, is that a number of these patients are very young in very particular clusters. So not only are they particularly young, but again, as I said, they're male, and in some of the clusters, they're actually all male patients. So if we were to stop there and undertake no further analysis, and as you can imagine, Julia and I have been looking through these slides and information in quite some detail, you can immediately take some data from the system that describes we have particular GP clusters that we might want to then further analyse to understand why there seems to be a specific age range and actually a male dominance, unfortunately, in the adverse outcomes that are being reported. However, we're not going to stop there, and although I appreciate that was quite a snapshot of the work in progress at the moment, this is the approach that we're taking across all of the 3 sub-pathways that have been described. We're also looking at cross-indications in the pathway. So, for example, patients who have reported adverse outcomes in both diabetic retinopathy and amputations. And once we start to move back through those pathways, what does that tell us about patients' access, reasons patients may or may not access the services available? We are currently moving backwards, for want of a better term, into the pathway for amputations. And we are looking, as we say, at the case mix and progressing further through the various interventions being experienced on the pathway. For diabetic retinopathy, we are working with the screening services to connect the reported adverse outcomes in secondary care to the management of patients living with diabetes and their screening services. And for expectant mothers, we are working towards an analysis that will identify the monitoring of expectant mothers and their condition and the impact that has on the baby during and after birth, which, as Julia described, is an area that we really have some opportunity to make some inroads. And really, before I hand you back to Julia, I suppose the part for me is this really was a snapshot in those slides of some of the information that we're collating. I feel very privileged to be part of this project. It's very exciting what we are trying to do, and we are really trying to look at the data we have available, bring it together across Wales and create a change to deliver optimum services and better outcomes for our patients. So I hope that's been insightful. I'm now going to hand you back to Julia, who's going to describe how we intend to move forward with some of this analysis.
Thank you, Claire. When I first saw this data, I said to Claire, that's such beautiful data, because, for example, the knowledge that a health board had excess amputations was not news to us, and it was not news to the health board, but knowing what was going wrong and how to address it was something that we didn't really have a handle on. You know, we'd be looking at root cause analyses and that sort of thing. But if we have data that provides us with this degree of detail, we can look further into it and really make a difference. So, for example, we've got an area. We know that the excess amputations are in men between the ages of 40 to 60 in that particular area. So what we need to know is a little bit more about them, but you can start to imagine what I mean. So I've just given a couple of, for instances, what we might find. So, for example, perhaps in this particular area where these men of working age with excess amputations are, perhaps they work in heavy industry in that area, perhaps they're wearing steel toe-cap shoes for work, perhaps they can't take leave, and this is why they get foot problems, and they get foot problems that don't heal. And if that was the case, then we could put in a different service for these men. We could put in an occupational health service, look at different footwear, and approach it through that way than the ways we do now. Or perhaps what further analysis will find is that these men are, perhaps they're unemployed, services are situated away from them, they have no transport and no funding to get to the services. Perhaps, you know, they're smokers and we need to put our resources into smoking cessation and relocating the services. Or perhaps none of these apply and it's just in that area the services are very poor. You know, people aren't recognising that people have a problem and are therefore not dealing with it. So what you can see is, depending on what the data shows, we can design a different service to tackle the problem. And I think one of the reasons that we haven't been making inroads into some of these problems is that we don't know what the right answer is. So we keep doing more of the same. And obviously if you do more of the same, you don't get a different outcome usually. So this is very exciting for us. And again, we'd ask the same questions in retinal screening. Why don't people come? What is the reason? Are the times wrong? Are the places wrong? Do people not know that it's important? All these things are possibilities, but once we know, then we can fix it. We can have different locations, we can have different times, different systems. You know, what is happening with hospitalised services, that the delays and cancellations can lead to people losing their sight, and what the solutions can be. So once we know what the actual underlying problems are, we can start to fix it. Why are so many women poorly prepared for pregnancy? I know women are so motivated during pregnancy. You know, they'd walk across hot coals to manage their baby. So there's something that we're doing wrong. Is the advice not in the right place? Is it not in the right format? Is it not in the right language? Are women empowered? Can they get through the system to present early in pregnancy, or do they become all stuck up with red tape? So these are the questions that we're asking. Why do we have this variation? And it's very exciting for us to have this data, because once we can get to the detail of what the problem is, then we can start to do some real bespoke service planning to fix the problem. And I'm going to stop there and throw the floor open for questions.
Thank you, everybody. Hopefully you will have found that, and I can see certainly from the questions we have that there's a lot of engagement in the session. So thank you all for joining and taking part. We've had a number of questions, which I think between you and I will be able to hopefully answer, and any we don't answer, we will come back. We've had quite a few, if I may take this one first, which is about actually the data and the data we're presenting and the data we're analysing, there's some themes coming through with regards to the use of standard deviation from the mean. Are we going to use SPC methodology? And I think what I would say to that is Julia winces slightly. So we are very much, we've actually managed to achieve quite a lot of work with the great dashboard and analytical support we've had with the team here. We actually also have a long way to go. So we've gleaned some fantastic insights, but we are working throughout those 3 pathways, and we have much work to do. And along that way, we will absolutely invest some time in the best ways to consider the data, consider adjusted population views of the data. So in answer, yes, but we very much definitely have a bit more work to do. We've had another question in which asks if we are going to be including PROMs at the various stages across the pathway.
Yes, is the answer.
Yeah.
Yes is the answer to that. Yes.
Yeah, so we have there's variation in the collection of PROMs for patients with diabetes across Wales, but that will be a component that we will build in where the data is available. We've had another question with regards to making this data available to practice level and to support decision making. Is that something we're going to do? I don't know if you want to pick that up, Julia.
Yes, I mean, at the moment you can see that this goes down to cluster level, but it's certainly possible. The national audit data is available down to cluster level and practice level for the individual practices, and where we can get something meaningful at practice level, it's entirely possible to do. It's entirely possible as well once we have themes emerging and we find variability, for practices to look at their own data to find the variability as well. So there's an awful lot that can be done with the data.
Yeah, and I think the other point to add is that you're hearing from Julia and myself today. There's a lot of individuals helpfully invested in this project, which include connections specifically to GPs. We have Alistair Rose working with us, and Dr. Sally Lewis is supporting this project as well. So the intention, as I say, because we're very much at the we're starting at the end of the pathway, but very much at the beginning of our own in terms of analysing the data and then engaging. We have, it's probably worth mentioning, we have a clinical reference group for each of the pathways established. I don't know if you just want to mention that in terms of our approach.
Yes, so for each part of the data we have a clinical reference group so that we can look in detail and think about the data further. But obviously what we expect to find out with this is that there is a way that we can intervene further down the pathway to stop people progressing down the pathway to these harms, to stop people progressing to the fact that they get an ulcer or an amputation, that they get severe retinopathy, that they have a harm in pregnancy. And it's asking where can we put our resources differently so that we are preventing things rather than spending a lot of money treating things that, if you like, cannot be improved. So that's really the whole idea. And undoubtedly this is going to involve primary care, because this is where a lot of people start out. It involves the community, which is where a lot of people start out, and it involves as well the person with diabetes, because more and more what we know is that patient activation is really key to outcomes. So for example, if you've got a foot problem, having a person who knows when to recognise it and how to act is absolutely vital, rather than somebody almost going into the big healthcare machine and sitting on waiting lists and waiting for things to get worse and worse.
And if I may, because we're on the cusp of time here, just squeeze one last question in, which was about that this will focus and help these particular 3 sub-pathways of diabetes, but there are so many more that we've described. And what's our hope for the future on that?
Well, our hope for the future is that we would move everything downstream in diabetes. Everything that I mentioned that is a complication of diabetes is usually something that it's an end process. So for everything, we'd like to look more at the possibilities of intervening earlier and stopping the whole end process being reached. So I think this is just a new way of approaching things. It's a new way of thinking about healthcare resources, and it's a more proactive way rather than the reactive way of waiting till the problem has happened and then trying to deal with it.
Okay, so I think we're out of time, so thank you for me.
Yes, thank you very much for joining us today. Please remember that there are loads of other great sessions on today, so don't miss them. You can check out the programme today on the website, and please join us later today. But thank you for joining us. Thank you.
Thank you, bye-bye.